Hello, my name is Micheline Cormier, and I'm happy to present my IRB proposal on the effect of vitamin D supplementation in the treatment of systemic lupus erythematosus-related fatigue in patients with vitamin D insufficiency. Vitamin D is a steroid hormone that regulates the cells of the immune system. Evidence demonstrates that a deficiency plays a key role in the development and progression of autoimmune disease like systemic lupus erythematosus, which I will refer to as lupus throughout the presentation. Vitamin D deficiency and insufficiency are common in lupus due to the avoidance of sun, photosensitivity, kidney disease, and the use of certain medications like steroids, which alter the vitamin D metabolism or cell receptor activity. As a result, lupus patients might be at a higher risk of suffering from low vitamin D levels. Lupus is a chronic autoimmune disease marked by inflammation of the blood vessels and connective tissues throughout the body. It can affect most organs and lead to death. It is on the rise, with cases having tripled in the last 40 years. While it commonly affects Blacks and women of childbearing years, it is most prevalent in North America. The etiology is unknown. However, potential causes are related to gender and environmental factors like low vitamin D levels. Fatigue is the most debilitating symptom in lupus patients. Reviews indicate that vitamin D supplementation improves disease activity, including fatigue. However, the results are inconsistent. It has also been suggested that lupus patients might require larger doses of vitamin D in order to counteract the increased need due to medication and inflammation associated with the disease. However, the medical community remains without treatment protocols for the effective use of vitamin D in the management of autoimmune activity. Accordingly, this research will answer the question, how does long-term vitamin D supplementation affect lupus-related fatigue in women 19 to 50 years of age with serum 25-hydroxy-D levels between 20 to 30 nanograms per milliliter? Of note, vitamin D levels will be used interchangeably for serum 25-hydroxy-D levels during this presentation. The study will also look at the relationship between vitamin D levels and fatigue and BMI and fatigue. In the end, the study will demonstrate that long-term vitamin D supplementation reduces lupus-related fatigue in women 19 to 50 years of age with vitamin D levels between 20 to 30 nanograms per milliliter. How do we obtain vitamin D? There are a limited number of foods that naturally contain vitamin D, such as fatty fish, like salmon, mackerel, irradiated mushrooms, eggs, soy products, or fortified foods like dairy and non-dairy options like coconut milk. However, for most individuals, sun exposure is by far the ideal way to optimize vitamin D levels, as it is responsible for up to 90% of our circulating vitamin D. As mentioned, this might not be an option for patients with lupus. Vitamin D metabolism is fairly complex. There are two ways to obtain vitamin D: exogenous sources like the diet and supplement, or endogenous sources like the body's production by the skin using ultraviolet B rays to convert a previtamin compound to a vitamin form. Regardless of the source, vitamin D must be activated in order to have beneficial effects in the body. For this to happen, the vitamin must be transformed twice by enzymes, once in the liver and once in the kidneys. At this point, it is ready to enter the cells, where it is responsible for controlling up to 200 genes and 160 metabolic pathways, some of which play key roles in immune function. RDAs have been determined based on the need for bone health only, and scientists agree that this might be too low for diseases like lupus. Vitamin D toxicity is rare and is most commonly associated with excess supplementation and serum levels greater than 150 nanograms per milliliter. In the study, serum calcium and phosphate, as well as urine calcium, will be monitored every 3 months to prevent toxicity. Hypovitaminosis D is a common deficiency with many consequences. It affects almost 80% of people worldwide, and it can affect any system because vitamin D cell receptors are throughout the body. Consequently, the role of vitamin D in the prevention and treatment of lupus warrants our attention. Serum concentration of vitamin D is the ideal gauge of vitamin D status because it reflects both the endogenous and exogenous intake of vitamin D. Also, it has a fairly long circulating half-life of 2 to 3 weeks. There's significant debate on how to diagnose deficiency or determine optimal overall health levels. Consequently, this study will define vitamin D insufficiency as 20 to 30 nanograms per milliliter and optimal levels at 40 to 60 nanograms per milliliter, as per the Institute of Medicine, which also coincides with levels demonstrating immune effect. In literature, there's convincing evidence to support an association between vitamin D and lupus disease activity. In 2016, Lima et al. Conducted a randomized trial on 40 lupus patients. Participants were assigned 50,000 international units of vitamin D per week, or a placebo for 24 weeks. The findings correlated with decreased activity and improved fatigue score. Similarly, Magro et al. Conducted a 12-month prospective study on 33 lupus patients with vitamin D deficiency or insufficiency. They took 8,000 international units per day for 8 weeks or 4 weeks respectively, after which both groups took a daily maintenance dose of 2,000 international units. The results also showed improvement in disease activity and fatigue. As a result, this study will combine both of these protocols. This will serve to normalize vitamin D levels, then maintain optimal levels in a safe manner. This study will be a multi-center, 12-month, 2-arm, randomized, placebo-controlled double-blind intervention. Under the supervision of the Lupus Clinical Trials Unit of the NIH, it will take place at the top-ranked rheumatology centers of Johns Hopkins University Hospital, Mayo Clinic, Brigham and Women's Hospitals, UCSF Medical Center, NYU Langone Orthopedic Hospital, University of Michigan, and the National Institute of Arthritis and Musculoskeletal and Skin Diseases. Recruitment strategies will include flyers, listservs, and word of mouth. Participants will be invited to call for a pre-screening interview with dedicated medical professionals. Qualifying participants will then be invited for an in-person interview with the research coordinator. Inclusion criteria are female patients from the participating centers who are 19 to 50 years old with a diagnosis of lupus, a disease activity score equal to or greater than 1, and vitamin D levels between 20 to 30 nanograms per milliliter. Exclusion criteria include a disease activity greater than 12, autoimmune disease, kidney, intestinal, or liver disease, pregnancy, elevated urine calcium, or receiving treatments for osteoporosis, or taking large doses of immunosuppressant drugs like steroids. Based on an a priori calculation using G-Power, 154 women will be recruited for the study to have 80% power and a medium effect size. These study parameters are in line with similar studies in the field of clinical nutrition and compensate for common attrition rates. The consent process will be initiated at the in-person interview. It will include the form information, the risk and benefits of the study, how data confidentiality will be protected, and participants will also be explained that they may withdraw from the study without any penalty or consequence for any reason at any time. Also, these communications will be provided in writing as part of the consent agreement. Participants will have up to 2 weeks to decide to take part in the study. Before randomization, there will be a 3-month washout of vitamin D period by all patients to reduce the carryover effect of any previous supplementation. Then, patients will be randomized into the treatment or control group. All patients and physicians will be blinded to group assignment and treatment allocation. The treatment group will receive 50,000 international units per week for 12 weeks, then 2,000 international units per day for the remainder of the study, while the control group will receive placebo tablets for the duration of the intervention. All medication will be dispensed free of charge at the participating hospital pharmacies. Compliance will be assessed by pill count and return tablets and by weekly phone calls to all patients from the clinical coordinator. Anthropometric data, laboratory values, and disease activity or fatigue level scores will be collected by medically trained professionals at baseline 3, 6, 9, and 12-month intervals and recorded in the participant electronic record. Questionnaires will be used to collect demographic and additional data like time of year enrolled, significant sun exposure, changes in vitamin D-rich food intake. Disease activity will be assessed using the Systemic Lupus Erythematosus Disease Activity Index 2000 glucocorticoids index, a validated and novel measure of lupus disease activity that takes into account steroid dose, making it more sensitive to changes in disease activity. The visual analog scale to evaluate fatigue severity is a common tool used to measure fatigue severity, and it will be filled by participants on the same day as the blood draws. Blood and urine parameters will include those commonly used for lupus management and vitamin D toxicity monitoring, like vitamin D levels, complements such as C3, C4, C-reactive protein, antibodies, PTH, urine calcium, and microalbumin. Statisticians will be hired to analyze the research data. This will be performed using the statistical package for social sciences program. A student t-test will determine the statistical difference between the study group and control group for continuous variables, including serum vitamin D, C3, C4, C-reactive protein, antibodies, complete blood count, urine microalbumin and calcium, fatigue severity, and disease activity scores. Categorical data like age group, race, time of year, sun exposure will be analyzed using a chi-square or Fisher's exact test as appropriate. Non-parametric results will be addressed using the Mann-Whitney test, and data results will also be added into a logistic regression model in order to control for confounding variables like age, race, BMI, significant sun exposure, vitamin D-rich food intake. The prime analysis will be using an intention to treat model to avoid bias. Lastly, the significance will be set as a two-sided p-value of less than 0.05. Data protection is paramount and applies to all forms of data. Research identification codes will be used in place of PPI. Access to lists of master codes will be limited to principal researchers and coordinators. Electronic files containing data will be password protected and encrypted. Electronic data will be only stored on password-protected computers, and when no longer required for the study, any data, including PPI, will be destroyed according to hospital or research center policies. All research staff will be trained on these procedures, and disciplinary procedures will be in place and strictly enforced in the case of a process breakdown. The benefits of this study outweigh the risk. While there's a rare chance of toxicity, hematoma, or bruising, the study might improve the quality of life of patients with lupus. Current standard of care for lupus is to treat with drugs that can contribute to organ damage. Additionally, the medical treatment requires significant monitoring, which can cause financial burden. As a result, discovering safe, non-toxic, and affordable adjunct therapies like vitamin D might not only help control disease activity, but might also provide a cost-saving treatment option for those on a limited budget. Lastly, this study might help the greater good by providing a rich data set that could translate into treatment protocols for others with this disease. Currently, there are no treatment protocols for lupus-related fatigue that include vitamin D. Significant findings could help create care maps for the treatment of patients with lupus fatigue. For example, the data might be used to develop guidelines for doses of vitamin D based on serum levels and severity of SLE fatigue. This novel intervention would also be a low-cost treatment option with minimal adverse side effects used to improve the quality of life of patients, and it might demonstrate effectiveness in reducing disease activity such as flare-up, therefore reducing disease progression. There are some key strengths. This topic is current and impactful. It has practical application. It can help create treatment protocols to be used with lupus patients, and it builds upon existing research. By combining short-term and long-term protocols and using a more sensitive tool to measure disease activity change. Among some limitations are high cost, length of study, multi-center approach, and the structured environment, which are common with clinical control trials. The significant findings could help to elicit future studies with broader populations, including men and women, vitamin insufficiency and deficiency, and conditions of free living. It could also help further support the causal relationship between vitamin D supplementation and lupus. Thank you very much. I appreciate any feedback.